Great. Good afternoon. This is Ed Yerkison. I'm the Chief Product Officer at Onyx, and I'll be the moderator today. Thank you for joining us. We expect to have a great conversation on how health plans can leverage the CMS mandate and the corresponding data standards in order to create some sort of interoperability platform that can really be the foundation for a health plan's data strategy. Rather than viewing the CMS mandate compliance as a data exercise, can it be viewed as an opportunity to implement a strategic interoperability platform? And joining us today, we have Josh Mandell, Aneesh Chopra, and Seib. Josh is the Chief Architect for Microsoft Healthcare, as well as being the Chief Architect for Smart Health IT. Aneesh is the President of CareJourney, the Co-Chair of the CARIN Alliance, and has been driving healthcare interoperability since his time as the first Chief Technology Officer of the US in 2009. Aaron is the Chief Strategy Officer for Onyx and has been instrumental in creating the FHIR platform. Aaron has been a champion of consumer access and is actively involved in the CARIN Alliance, the Gravity Project, and ONC's FHIR at Scale Task Force. Josh, we're going to start today with you. Can you help us understand how data standards are crucial for interoperability to really be impactful?
Absolutely. And what I want to do from this perspective is to share a little bit of history and talk through two major areas where I think we need standardization to support the kinds of workflows and connections that we really need in the health ecosystem today. So a little history lesson that's going to come from the perspective of clinical data access, but a lot of the reasoning here you will see direct analogies in for healthcare financial data access as well. And so this is sort of my view of the meaningful use and electronic health record certification program condensed into a single slide. And this has been a major effort in terms of health data policy and investment at the national level in the US over basically the last decade. And regulation has come from two important sides. One has been from the Office of the National Coordinator for Health IT. And effectively, ONC runs what's called the certification program. They set baseline technical requirements or technical expectations for any certified electronic health record product. And there's hundreds of products like that out there today. And they tend to be the EHRs that clinicians use day in and day out to take care of patients, do electronic prescribing, and generally kind of manage their clinical practice. Those certified products are used at everything from small outpatient clinics to major inpatient medical centers and everything in between. So ONC runs a certification program that sets some technical requirements for those products. And then at the same time, the Centers for Medicare and Medicaid Services sets up expectations about how those electronic health records are deployed and used in practice. And that's through many different levers, including some mandates and including some incentive programs that get healthcare providers to not just buy the right products, but also to configure them and make those features available in certain ways to a variety of end users. And so today we're going to focus on patient access throughout that meaningful use and EHR certification lifecycle. And early on in the very first round of certification, so this is like looking all the way back to 2011, but I think it's actually a useful exercise to think about how we've been closing these gaps and think about the importance of interoperability through this lens. So way back in 2011, the basic expectation for these products was that every certified product would be able to provide patients with an electronic copy of their data. So it basically said every product needs to have some way to generate or aggregate certain kinds of standardized documents. And the rule of thumb here was a health summary document. The idea that at a given point in time, it would be possible to put the relevant information, the sort of basic summary data about an individual into a document that would be in this XML format known as the CDA, Clinical Document Architecture format, and wrap that up and somehow be able to provide it to a patient. So the nice thing there is that there was a standardized data format for these summary data, but there was really no workflow. Every product might have a totally different process for how to generate one of those documents and how to provide it to a patient. So it was a good start, but it was entirely focused on data and really not very much on workflow. So fast forwarding a few years to the second round of ONC's certification program and roughly the second phase of the meaningful use program from CMS, we introduced the idea of VDT, view, download, and transmit. And the idea here was to say, well, sure, we've got these packages of data. We know what the package looks like, but let's also introduce a consistent workflow for making those packages available. And the idea would be not only could you see the data in a portal somewhere, but you could navigate through that portal to download the data, save it onto your own computer, and then there would also be a feature in that portal that would allow you to trigger the transmission of that data payload to basically a secure email address of your choice. And this was really an advance because it established not just the data, but it established sort of a consistent workflow expectation across all these products. And yet at the same time, these features had trouble finding the light of day. Basically, every patient portal implemented support for these things, but they were often buried. And that's sort of my own personal assessment of the situation. They were often buried inside of these portals, and you'd have to navigate deep into a settings screen somewhere to find that feature that would let you either download a file, and that worked, but increasingly people were using mobile devices. Patients and consumers wanted to access their data from a phone or from a tablet, and often there's no good file system management on those mobile devices. So when you download a file, like where does it live and what do you do with it? It's maybe stuck on your device somewhere, but not obvious how to get it. So download didn't work that effectively, particularly on mobile. And then the idea of transmission, which was this really powerful concept to say, I want you to send my data to a certain endpoint. It was a powerful concept, but it really did not work in practice. And the first issue was just how did patients know what to put in that lurking, looming text box that said, where do you want to send your data? Any email address wouldn't work. It had to be a particular kind of secure email address designed for healthcare. And not even any secure email address would work. Somehow you had to make sure that the recipient of this email would be part of the same trust network as your healthcare provider. Otherwise, the message wouldn't get sent. And so the features were there. Every product supported them. But in practice, they were buried in the portals where they didn't really work. So fast forward to 2015, we're making incremental progress through each stage of this process and learning from industry experience at the same time. ONC introduced the idea of patient API access. And this was not just talking about the data and not just talking about a workflow that might exist buried in some portal somewhere, but actually the idea that you could connect an app to your health record and that the workflow might be initiated from inside of that app. And this was, again, a powerful step forward. But in 2015, we did not yet have the standards in place. So the functional requirements that went out with those EHR certification rules basically said every vendor is allowed to create an API as long as it does these same kinds of basic operations. So as long as your API allows you to search for a patient's medications and search for a patient's allergies and so on, that would be a valid API, even though every certified product might choose to do it differently. So it created these functional requirements, but we saw a fair amount of divergence in the actual marketplace, which made it very difficult for an app developer to build an app that could be integrated into multiple products without having to invest in different connectors and translators for every system that you wanted to talk to. At the same time, though, there was a very clear ray of hope as a core group of EHR vendors got together under the banner of an effort called the Argonaut Project. And this included some of the major EHR vendor products. And they said, even though there's not a requirement for us to do it this way, we want to get out there ahead of the requirements and actually work on a standardized workflow. And so that group of vendors through the Argonaut Project really nailed down the details of how to use the smart on FHIR standards and built out implementations that they pushed into production even ahead of any strict requirements. And so those APIs are available at hundreds of provider sites today across the country. And critically, that effort allowed ONC to really tighten down the rules this year. And so finally, we make it to the present day, where we have a set of rules that were published by ONC and landed in the Federal Register this May that requires every certified product to support not just patient API access, but following a specific set of technical standards that includes data format and also includes a standardized workflow through this OAuth process. And that's a really core improvement over what we've seen in the past. Focuses on the end-to-end integration between an app that a consumer can choose and the underlying portal. And so we get a lot closer from an app developer's perspective to saying, you can start to build functionality that's going to be valuable not at just one clinical site, not for just one underlying vendor product, but across the market. And Ed, if you don't mind going to the next slide, I'll talk just a little bit about the specifics of those requirements from 2020, so from this year's ONC final rule. And again, this is ONC focused, So these requirements, in many cases, are describing APIs that providers will offer, but the very same underlying technologies, the FHIR specification and the API surface area that we'll talk through here for providers, those same standards are pointed to by CMS in terms of healthcare financial APIs. So we really have a common basis on which to build. So the rules that came out this year from ONC require, first of all, the support from every certified product for what's called the Smart on FHIR app launch protocol. And the basic idea here is that if you are starting from a consumer app, it could be something like an Apple Health Records app that's going to help you pull all your records into one place. It could be something specific to seeking a second opinion or shopping for help.
Josh, I think we have lost your audio. Aneesh, can you hear me?
I hear you just fine, Ed.
All right.
And I'm happy to fill in as Josh continues. He was making great progress on the history. Yeah, I think the main principle here is that the very same standards that are applied on the provider side will be carried over onto the plan side. The particularly interesting features on this graphic are the ability to extend that patient-facing application infrastructure towards any provider-facing app. I think that's important for the plans to hear that message as we think about plan application strategies as it relates to provider-facing apps. The current state is that you can query for individual patient records within the EHRs that are certified to meet the historical 2015 edition. But as we move to the 2020 requirements, what Josh defined as the 2015 revised, in the next 2 years, those very same EHR systems and the plans that are going to comply with a similar requirement will have the ability to export bulk data, the capacity to ensure a group of patients, perhaps all patients in a doctor's EHR that are attributed to a particular plan, or plan A, grouping the patients that have transferred over to plan B for data sharing. And in both scenarios, these revised 2015 requirements will be coming to market, and they are relevant in the context of compliance activities for plans, but as well the broader application strategy amongst those very plans. Okay. That's my best guess at where Josh was heading, and I'm happy to carry on as you move to the next slide to sort of carry that message forward.
Yeah, the next slide is talking about information blocking and really the future of these standards and helping us understand, are the standards fixed in time now, or do you actually expect them to be evolving over the next 24 to 36 months or even further?
Yeah, actually, this is a very important slide that Josh would have reviewed, and I'm happy to do my best to share some context on. If you look at the very first set of dates, that blue at the bottom, 6 months after publication, compliance starts for information blocking rules. There are some very specific capabilities in the information blocking domain that have relevance to a payer strategy. Number one, all providers from November 2nd on are required to make clinical notes accessible to patients. It doesn't describe the content or manner, so payers or payers working with consumer designated apps may seek these clinical notes, but may not get them in a structured or standardized format or via the workflow that Josh had alluded to. But at least the content, the clinical notes, that is required to be made available. One friendly amendment to my statement about 6 months after publication: while the rules technically kick in November 2nd, there's already been a 3-month delay on enforcement discretion. And we have a new rule just posted to the Federal Register that has not yet been made public, but we know the rule exists in title, and it likely involves another, maybe, let's all guess, 3 months or at most 6 months delay on enforcement discretion. So item number one, clinical notes from the provider's EHR will be something that will have to be made available. And then secondly, the perhaps more interesting to the audience at hand, the provider's willingness or ability to install a third-party app in their workflow will be available for doctors who are on a 2015 edition certified EHR. And if Josh is coming back, I'd rather have him describe.
I am back now. And I apologize, my computer just hard crashed. And then I went on blathering to a frozen screen. So I don't know quite where I lost you all.
Well, Josh, we just went through the Smart on FHIR launch and some of the capabilities that are introduced in the over the coming years. We've now moved into the certification timelines, and I was talking about the obligations for EHR vendors to enable application access to EHRs, and you're welcome to pick it up and move it in a different direction before I dive into my section.
Perfect. All right, so I'll wrap this up just over the course of the next couple minutes, which is to say, as the timeline slide here shows, and I put a yellow box over what I think is probably the most important deadline on the whole screen, which is within 2 years of this May, so by May of 2022, every certified product needs to have a way to run smart apps, both for patients to connect apps to their own health records, and also for clinicians to run apps inside of the EHR system. And that's really powerful for giving patients control, but also for giving clinicians access to better tools that integrate with their workflow. So a clinician-facing smart app can do things like providing decision support, medication management tools, or showing a clinician information from outside the EHR, like maybe where else a patient has received care or what services their insurance will pay for. So all of that gets rolled up into the requirements for 2022, as well as those population level APIs that do data export across an entire population of patients, which could be every patient that your health system sees, or patients in a specific group. So if your health system and an insurance company are managing together a risk pool, it would be possible to export data about the patients in the specific group corresponding to that risk pool. So by May of 2022, those smart app launch APIs and those bulk data export APIs will all be supported. And they are all focused on what's called the US core data set. So it's an important large slice of clinical data as well as free text notes that cover the things that we sort of know how to standardize well today. And ONC also has a process for expanding that core data set over time. So what was published initially is what ONC calls version 1 of the data set, with about 20 different types of data that get shared. But over time, there's a process for expanding that data set as the growth, as the boundary of what we know how to standardize in the community grows. So all that focused on 2022 with basically yearly updates to the definition of that core data set. And the only one other piece of information that I want to point out on this slide is the final line that you see here, 36 months from publication. So that means May of 2023. And that's the date at which every certified electronic health record needs to support EHI export, electronic health information export. And that's not necessarily an automated API. It could just be sort of an administrative control for somebody running the EHR to be able to do an export either on one patient or on everybody in the system. The really interesting thing about EHI export, though, and the reason that I call attention to it here, is that it represents a different point on the trade-off curve between completeness and standardization. So all the APIs that we're looking forward to in 2022 are highly standardized. They lock down a lot of details about transmission and data formats, but they don't cover the whole record. And the feature that comes out in 2023 is a complementary feature that says, here's some way to get the whole record. It might not be standardized, but everything will be there. And so this provides sort of different angles of attack on getting access to the data that you need for your particular purpose. So I'll pause there, and I apologize for cutting out in the middle of the session.
No problem. Thank you, Josh. So Aneesh, it's on to you.
Thank you very much, Ed. To pick up on where Josh just left off, I thought what I might do is highlight a bit of the broader strategic options on the table. Many of you on this webinar are hard at work preparing to comply with these rules. That would mean on the plan side, building that patient access API. And what I wanted to leave you with in my remarks is the opportunity to lift up and to establish more of a a data governance framework, of which compliance with the rule is simply one item on a menu of items you might contemplate moving forward. I refer to this as API first data governance, and I'm going to go backwards to Josh's comments as I come forward on the opportunities. So let's go backwards first. When you read the CMS final rule, it is important to read the language that implies intent or industry suggestion. And to me, the part that had my time and attention focused had been what I referred to as the assumption of the demand signal for clinical data that is a requirement in the patient access API. Today, many plans have business units that collect clinical information for whatever purpose: prior auth, risk adjustment, quality measurement, maybe even patient engagement and care coordination. For whatever business case over the last 5 years you've been working on ingesting clinical data, CMS is putting a stake in the ground that clinical data maintained in your systems, and in my opinion, by the way, maintained in your systems includes data subject to audit, would be required to be transformed into the format of the FHIR API format, and in particular, the FHIR R4 standard, the clinical data standard that Josh just referenced on the provider side. In fact, I found this to be funny. I called this payers going first. Payers are going to be publishing an R4 FHIR server by regulation sooner than the 2 years from now requirements that Josh alluded to on the provider side. So in a weird way, the newest participant in the API community is going actually first on the more advanced standards, which I think is fascinating. But it is the quote from the rule that I wanted to highlight in this API first data governance slide. Quote, "It will be up to each payer's discretion to address whether this information, clinical data out of the EHRs, needs to be included in contracts with providers." My rough estimate, both informally and actually a bit more broadly amongst my payer friends, is that today there are often data sharing provisions that highlight the need to share data without getting into the weeds of the how. My view is in this CMS rule, by having you specifically deliver the how, clinical data, FHIR R4 to consumer designated apps, there's a chance for you to connect that requirement all the way up and down your supply chain. If you contract with a PBM, you may demand that they provide that data in the FHIR R4 format. If you contract with another clinically integrated network, you should ask for application access to the EHR. As the providers move to bulk FHIR, you'll have the ability to plug your apps directly on top of that EHR infrastructure. And that may be an aspiration over the next 2 years. But in the interim, there's a lot of opportunity for experimentation and creativity. Single beneficiary access, patient and provider facing capabilities. These are all capable of making this information available to the plan, who ultimately has to make it available to the patient. So that's point number one. Payers are up first. And taking this data governance approach, you might want to think about how the various supply chains that contribute the data to the very data set you have to make available can assist you in that cause. As Josh alluded to, the second feature here is the bulk requirements, both on payers and providers. It's important to note here that as we move to this bulk infrastructure, there's a little bit more authority granted to providers that says EHR vendors have the obligation to make this process, approval of bulk FHIR apps, something that local provider networks can control. In other words, one need not go to only an EHR vendor's app store in order to tap into their network of EHR data. You may still choose to do that because it's useful to you and you see ROI, but the rules give a lot more flexibility as to individual control over application access decisions. If you're interested in this idea of API first governance, I will make the following statement. Many of you on this call have the ability to build FHIR applications today because CMS is live not only on their beneficiary-facing FHIR service, the Blue Button 2.0, they're actually live on bulk FHIR services. Some of you payers sponsor Medicare ACOs. You have sort of a pay-vider relationship. Every Medicare shared saving ACO today can access a bulk FHIR server to pull CMS claims data exactly in the manner that bulk FHIR would allow any stakeholder to participate in 2 years. But for the standalone prescription drug plans, about a week and a half ago, CMS also announced that every one of those standalone plans, with a click of a button on the CMS health plan management system, can request the Part A and B data to complement to your Part D claims, so you can build a much more sophisticated program for medication adherence, care coordination, and the like. Bottom line on this slide, if you're only complying with the rule, you're missing an opportunity to put in place the data governance principles that will drive the successful strategies for your plan in the coming years. Go to the next slide, Ed. Let's just play this scenario up a little bit. To me, in my advice to plans, there should be, concurrent with the compliance strategy, a set of application investments that allow you to ingest FHIR-based data, just as you will be obligated to make it available to third-party apps. And that the more you build these applications on a must-share regulatory foundation, the easier it is to understand what the possibilities are and the principles are for improving overall patient care. So let's go in order of the must-share requirements. To me, you will have third-party patients designated apps knocking on your door. And we know about Apple Health and the Android alternative in Common Health, and those are going to be relatively free and ubiquitous options on the market. And so you certainly can encourage them to come to your developer portal and to begin onboarding them. Or you may build your own or partner for a consumer designated app that you yourself are sponsoring. And that this app not only would pre-configure out of your own patient access API, in other words, this is your opportunity to dog food your own, what you're building for compliance, but it can connect to any doctor's EHR within your clinically integrated network. So even just the process of taking a third-party app, preferably one that you've designated, to make available to your members, and to do the last mile work of connecting those apps to every doctor's EHR in your network is itself an opportunity that one can work on today. It's built on a must-share foundation. No BAAs, no contract requirements, no third-party fees. The second category of apps, I'll call them must-share, but this one's a lot more in quotes. Josh alluded to the fact that over the course of this new rule, over the next 2 years, EHR vendors have to ship that Smart on FHIR workflow, not only for consumer apps, but for provider-facing apps. There's actually a little bit of a gray area around how those provisions, the information blocking rules, actually unlock this capability on existing 2015 edition EHRs. Now, we'll probably have a healthy debate in the coming months as an industry as to whether they do apply or they don't apply, and it may be subject to lawsuits and debates. But for this discussion, whether it happens now or in 2 years, the second question of what's must share is whether or not a plan builds a provider-facing app that is meant to support that provider's workflow requirements. And the most obvious use case that is available in the market today is the requirement by CMS that every hospital deliver to a doctor who requests it the admissions, discharge, and transfer feeds for any shared patients. A use case for those of you on this call looking to build provider-facing apps may absolutely be the a provisioning of an app to upload a physician's panel of patients, to negotiate with the area hospitals the matching to ensure that if a patient shows up in that ER, a notification is routed back, and then to deliver that information in context within a physician's EHR. Everyone on this call can work with your provider networks to sponsor a provider Smart on FHIR app that can perform the function of connecting these ADT feeds, even if they rely upon a local HIE or a private HIE. The app can still wrap that HIE service with some workflow tools like upload the roster, maintain the roster, put the information back into workflow in context. And then last but certainly not least, if you're getting experience building consumer apps that must connect, provider apps that can choose to be connected by the doctor and must be connected to their EHR, that leads us with the final category of applications, an application focused on a payer-specific population. Now, this is ideal in an era of bulk FHIR, where a built-in standard allows one in the EHR community to designate limited security and authorization token to just the group of patients affiliated with that plan or in that particular value-based care arrangement. But even before we get the bulk FHIR technology ubiquitously deployed, there is an opportunity for a payer to install a prior auth app or a decision support app, even a price transparency app, right in a physician's workflow that triggers off of that particular patient in the chart at which the doctor is looking, triggered off of your backend database. If you're not thinking about building apps, patient-facing, provider-facing, and those that extend the workflow obligations within your plan, I believe you're missing a significant opportunity when thinking about compliance in the rule. Let's just take a moment on each of these, and I'll defer back to Ed on the next part of our agenda. If you go to the next slide, let me give you some examples. We all know that this is the era of policy by tweet. Administrator Varma tweeted in May of last year, quote, "If you need help finding a plan that works best for your healthcare needs, but don't have enough time for all the tedious research, and by the way, helping my parents shop for a plan, it is super annoying having to manually enter all the drugs that they're on and thinking about the doctors they want to make sure are in the network. It's super annoying. All of you know the same headache. CMS Blue Button apps can help." So now there are 60 plus approved CMS Blue Button 2.0 apps. A third of those approved apps are for shopping portals. You can see a screenshot from one of the insurance brokers. This is I don't know who they are, redbirdagents.com. I'm sure they're wonderful people. They had a very fascinating offer to their agents. For agents that were selling the Centene Ascension joint venture plan in 4 markets, agents would get paid $30 for every CMS Blue Button application they were able to retrieve. That basically, presuming, is a table sale. The broker is sitting in front of the family, offering to personalize the shopping experience, inviting the patient to, or the beneficiary shopper to load Blue Button data, maybe to preload the medications list and avoid having to manually re-enter the formulary. Whatever the use case is, I'm not privy to it. I don't know Redbird agents, but it gives you an understanding that patient-facing apps, even during the shopping experience, are something that health plans are already doing. And by the way, this idea of connecting apps to EHRs is not, unique to just this payer discussion. This is a list on the right of all of the Smart on FHIR apps approved for consumer use within the Cerner App Store. And I highlight the fact that MyChart, the Epic product, is actually an approved app for consumers to pull data out of a Cerner EHR. This scenario of putting an app in the consumer's hands to pull in data from other entities, from the EHR side or the CMS side, or when the payer-to-payer exchange happens, to pull Aetna data out of Humana and vice versa. All of this can be done in that consumer bucket. You go to the next slide. I shared a bit on this ADT requirement. I thought it might be interesting to note. Again, quoting from the rule, the CMS rule puts a little bit of that, I call it network, I put it in quotes, network adequacy, while many doctors are expecting to tap the ADT feeds through one of the existing networks, again, public HIE, private HIE, vendor HIE, whatever. It is an interesting statement by CMS, quote, exclusive use of an intermediary with a limited ability to deliver notifications to the specified set of recipients, i.e. the doctor who's asking for it. What CMS is saying is, if you were to restrict it to only those providers within that network's footprint, quote, it would not satisfy the conditions of participation. In other words, if you're a doctor not on the network and you request the data, the hospital can't just say you must join the network. If the burden on you joining the network is too high, the hospital is not compliant. Quote, we require that a hospital must demonstrate it had made reasonable efforts to ensure that the system sends the notifications. Now, given the nuclear regulatory bomb, if you will, of losing your license to treat Medicare patients, I believe the ADT rule is the ideal vehicle to introduce provider-facing or physician-facing apps, since a physician raising his or her hand asking for it is entitled to it. Let's go to the last slide, and then we'll get ready to round out for Aaron. CMS is also actively recruiting payers through multi-payer programs to think about what I call payer-designated apps. This is a screenshot from the CMS app called CPC Plus. I don't know what the official name of this app is, but it is a tool in the hands of doctors enrolled in the CPC Plus program that allows them to drill all the way down into their beneficiary level data. And in today's world, as CMS launches primary care first, direct contracting, you see this sort of quote at the bottom of the page. In order to reduce burden and better enable data-driven improvement, CMS is encouraging multi-payer collaboration around data sharing. In my view, it's an invitation for plans to think about a plan plus CMS operating system, or a payer-sponsored app that can be a multi-payer sponsored app that gives it more value to the doctor by providing the decision support, the care gaps, and other resources to assist in that patient's care journey. If you go to the next slide, I think it may be the last that I'll wrap on, and that is this. I believe we have an opportunity to leverage all of this infrastructure, not only for improving payer-provider collaboration, but to think about all the regulatory use cases. CMS has launched a requirement that doctors ordering advanced imaging studies have to demonstrate adherence to best practice. While they are using bespoke vendors for the most part today, the Harvard Countway Library of Medicine has built a completely free Smart on FHIR app. Payers can build their similar decision support requirements, prior auth tools, and other capabilities off of the very same CDS hooks technology, and to begin orchestrating ways to embed that in their overall data governance plans. This, to me, is the moment in time we're in. Yes, all of you on this line has to meet a July 1 deadline, and I am extraordinarily sensitive to the amount of work this will take. But missing these opportunities to engage more broadly on data governance, to advance your value-based care strategies, to advance your patient strategies in terms of engagement, and to think about a world in which you're caring for the beneficiary, regardless of their insurance chassis, physician network, or any other historical legacy fragmented part of the delivery system, that you can be the fiduciary to drive patients more thoughtfully through our very complicated healthcare delivery system. And with that, thank you for your time, Ed. I'll hand the ball back to you.
Thank you, Aneesh. Just a couple of follow-up questions I wanted to get your opinion on.
Absolutely.
A lot about the exchange of data. how do you see the infrastructure that a payer needs to put in place in order not just to meet the July deadline, but we've seen that the January 22 deadline is actually where you have payer-to-payer exchange, and that's where I believe there's a lot of ROI opportunities. What do you see with the January 22 deadline, and what kind of, I guess, infrastructure do you expect organizations to need?
Yeah, so this is the issue of penny wise, pound foolish, which is one could probably accomplish the minimum data sharing requirement to comply with the rule in a manner that largely just puts whatever the expression is, chewing gum and baling wire on the fort, or whatever the expression is. One could probably get by. But I will tell you, and CMS, if they were on this webinar, would say the same thing. Building a single use case consumer-facing FHIR API, separate from these envisioned bulk use cases, which are coming in 2022, did add millions of dollars of overhead, because essentially CMS built the consumer blue button first and then built the bulk FHIR servers second. And that basically wasn't an efficient path. Of course, technically speaking, they didn't have the bulk option when they did it. So this is not a negative statement on CMS. I love CMS. But simply to say the lessons learned is, if you envision the fuller set of use cases and built your infrastructure to meet those use cases, current and envisioned, it is much more efficient to organize the infrastructure investments now to give you the optionality for requirements down the road. And just that same example, hey, CMS, you built the bulk FHIR server over here, you built the patient access API over here. There's not, they did share as much infrastructure as they could, but it could have been even more effective had they built all those use cases at once.
And this bulk FHIR infrastructure, the requirement is on the publishing, on the bulk FHIR publishing, but the opportunity, I believe, resides in the bulk FHIR ingestion. Do you see it in the same fashion?
Yes. In fact, half the slides I've presented are all about the ingestion. And so that whole idea of bringing in EHR data from your clinically integrated network in a FHIR format should lower your data transformation costs at a minimum. Forget all the value-added benefits of bringing EHR data in real time into your environment for all kinds of care coordination and care gap closure purposes. So for sure, if you are only publishing data out to consumer designated apps to meet the rule and not planning for ingesting data in either single beneficiary today or bulk FHIR in 2022, I believe that's a missed opportunity.
Fantastic. Great. Thank you.
Or not fantastic. It could be very sad if we miss the opportunity.
Exactly.
So Aaron?
Yes, Ed, I'm all set. I just want to kind of recap the two amazing speakers we had. And I think, there's two ways to do that. I think from Josh's presentation, we see that there's a lot of lessons learned, even what Aneesh was saying towards the end about the lessons learned for how CMS has approached this or been able to approach this. Really tells us that there is a path forward. And there's a lot of things that we've learned the hard way that we shouldn't be relearning as we build these solutions ourselves. I think the other big piece about this conversation so far from a strategic perspective is you can divide the path forward for decision makers on, do I check the box, meet the CMS mandate so that I can continue to service the lives that I have? Or do I start building a strategy around interoperability so that I can retain those lives? And in the future, as those lives that are employer-based, the commercial plans, become Medicare beneficiaries, be present, be ready to enable that interoperability. And I think that, our goal from this perspective on the Onyx call here is to share, what we've built, how we've approached it, talk about some of our experience, some of our history that went into this, our partners that went into building the Sapphire platform that we do offer today and is ready for deployment to production to solve not only the CMS mandate, but really position plans to be prepared to start taking advantage of all the use cases that Aneesh touched on. payer to payer, payer to provider, provider to payer, patient to payer, patient-generated health data. So we've been working on this problem. It was wonderful to see Josh sort of highlight, the last decade of all of our experience, right? And really where we've gone right and where we've gone wrong with the enabling patients to have access to their data. And I think, one of the highlights of what Aneesh was sharing was we have a mechanism in our hands today where the consumer is permitted and entitled, has a right to all of their health information, be it from payers, be it from providers. And they further have the right to authorize the sharing of that data with their family caregiver, with their payers, and so forth. And a platform like FHIR should enable that capability, and our product absolutely does. So when we think about how we got to where we are today with the Onyx product, we started more than 5 years ago, and we were the entity, our parent company, we are the commercial division of New Wave, actually worked on the CMS Blue Button 2.0 API. And to Aneesh's point, we learned a lot about how to actually do that at scale. And we learned a lot about what are the opportunities to build a design for an infrastructure like this that not only supports payer to payer, CMS, to consumer, Medicare fee-for-service beneficiary, but also bulk sharing of data from the provider or to the provider from the payer. So again, those lessons have been incorporated into the platform that we've built. A very important thing that I want to share with the team here is that what we've built, informed by the lessons learned from all the work that we did with CMS over the past 5 years, was built in partnership with Microsoft. It's not just a matter of, can I stand up an infrastructure? Can I find some open source components? Can I build a facade? But this is going to become much more than just being able to provide electronic EOBs to those consumers who ask for it. This platform, this interoperability, standards-based interoperability, is going to drive all the higher value use cases that we all think about, that we've all been pursuing since, frankly, since Bush signed the executive order establishing the ONC. And ultimately, what we want to talk about is an end-to-end platform for payers. There's a lot of ways to build this solution, cobbling together things that you might have in-house. There's a lot of folks out there offering parts of the solution. I think it's worthwhile, and what we'd like to share is our perspective of what an end-to-end solution looks like. In other words, what does it take to be able to not only meet the CMS mandate within a platform, but also to be in a position to be able to take advantage of that existing infrastructure that you pay within the investment to be CMS compliant, to enable the use cases where we're doing more to share information with providers, to share information with the integrated delivery networks that we leverage as part of our plan to becoming a digital health services company. So just a few things to touch on here. We've been working with Microsoft for over a decade at New Wave and now exclusively at Onyx. Over the last 2 years, we've built the FHIR platform end-to-end, leveraging a cloud-first, API-first design principles. This was built with Microsoft team engaged, working closely with their product managers, and we're currently engaged in the product owners' work in the direction of their strategic work in the health cloud that Microsoft recently announced. The thing that I think is really worthwhile is that the product that we have is ready for deployment to production. We built this using all of these software engineering skills of Microsoft and all of our lessons learned and all of our work with CMS over the last decade, as well as building it in a future-ready sense. So I think a lot of the things that Aneesh touched on was being ahead of the curve, right? We want to work with those strategic leaders in the payer space that are recognizing that there's an opportunity here to really transform how healthcare is delivered and how we manage risk and how we optimize outcomes. So when we talk about the CMS mandate, for example, the CMS mandate that we have today is certainly going to grow. CMS has already signaled that. But I think that the biggest growth is going to come from internal demands to be able to implement standards-based solutions within our existing enterprise end users. and further complement that by enabling caregivers to be more engaged, enabling social determinants of health use cases to be facilitated through standards-based mechanisms. We end up seeing an evolution, an explosion of these use cases that we can support, where in the future, with a platform like the one that we're showing here, a crisis like COVID-19 doesn't put us, knock us off our feet. And I think the big question is for folks who are looking at, how do I make sure that the platform that I'm building or the platform that I'm buying has all the components? Of course, this could be another 2 hours talk, but I think we've been able to communicate what we think is necessary in 3 major components. You have legacy data that is not in a FHIR format that you must share. So you need a capability that enables you to take all of your existing data assets and turn them into this data model that we call FHIR. You also need a mechanism that is not common to payers today, in the sense of enabling through an OAuth flow to authorize members to access and then approve and share their data with the app of their choice. Finally, we don't have many mechanisms in place in the existing enterprises to enable third-party apps to be reviewed and approved. All 3 of these components are necessary to really not only meet the mandate, but meet the mandate in a way that you're prepared for all the other mandates that are coming, and in a way that allows you to accelerate and achieve different ROI opportunities that aren't in the reach today without this type of platform in place. So first, and we spent a lot of time talking to plans about how to convert their data. How do they go from the legacy formats that they have, their legacy systems of record, data warehouses, all of the records that they've received in the HL7 or CDAs and so forth. You have to build that. And that's really just table stakes. Having the data in a FHIR compliant, scalable solution like the Azure API for FHIR is a starting point. But you also need the other 2 components to really get to the stage where you're actually sharing data with the consumer and engaging the consumer in those activities. As Aneesh kind of really spelt out, today, our shortest path to being able to help consumers aggregate their data and then authorize the sharing of that data back to our plans, back to our utilization teams, back to our disease management teams, will involve the Smart on FHIR flow and will involve patient access. We see in our CMS experience, hundreds of apps being developed around the notion of consumers having their data. We see this becoming very specialized to the particular needs of the family or the individual and their disease. What I think is really important to recognize is that the level of effort of approving all those apps, as we see consumers coming to us saying, I have a family with special needs, my son has autism, I need an app that helps support this, this, and this. I want you to authorize the sharing of my data with this third-party app. Our experience from working with CMS on enabling third-party apps to access these APIs it's a real burden. If you believe that you have in place processes that allow you to do this, I am certain that many plans have existing processes, but at the scale that we're looking at, just in the patient access space, the level of effort is extreme, is onerous without the types of workflow tools that we've built in to enable third-party apps to register, payers to evaluate those apps, and then ultimately decide whether or not to approve so that the consumer can use those apps. At the end of the day, without all 3 of these components, you will not be in a position to be able to readily and rapidly take advantage of the strategic differentiators that true interoperability that's FHIR-based would allow. Sushil, back to you.
Great. Thank you very much. It's now time for some questions and answers. Are there any questions? I think this has been a fantastic discussion. Thank you, Josh. Thank you, Aneesh. And thank you, Aaron. Wonderful.
Well, I would love to talk to or ask Aneesh and Josh what your thoughts are about the emergence of and how to reduce the burden on payer organizations and provider organizations in improving in approving these third-party apps. And what are we looking at today as far as consumer-controlled apps versus apps where we are sharing data with providers, or or is it a one-size-fits-all? Or are we looking at a lot of granularity around the approval process? What are your thoughts?
Josh, I'll happily defer to you. I could go on for quite some time on this subject, because I think the question you asked, if I may, on this one, Aaron, is a, let's call it the most strategic question out there, which is, how do we do the right thing by the beneficiaries we serve?
Exactly.
Obviously there's sort of a technical question, which is, by rule, you can't block. So if there's a terrible app that's going to give a terrible experience and offer terrible advice to people that you love, you really can't block them from using it, but you sure as heck would like to warn them that there are some risks associated. If every plan on this call develops their own framework for how they determine which apps are risky and which ones are given the risky designation because they're sponsored by a competitor, I don't think anybody on this call is going to be served well kind of going on their own. So to me, the collective action opportunity is to get the industry to embrace, at a minimum, the CARIN code of conduct, and maybe even more. I have this aspirational dream of a fiduciary standard where you're not so much worried about the privacy policy. Are you going to be selling the patient's data? I think we're going to clearly have that as a flag, but more importantly, is the decision support your app will run actually going to be in the best interest of the patient? And that fiduciary standard is not today recognized as a sort of an industry obligation, nor is it today even a functioning opportunity to invest in. But if we put some time and energy on the developer experience, onboarding the developers, flagging the developers, creating more transparency to the consumer as to what app A is going to do versus app B, we have a chance to lift our industry up together. And sign me up as a volunteer on the team that wants to help organize that developer experience. And that, again, not as a compliance exercise, how do we physically connect 50 apps, but to be more thoughtful about how do we make sure that the right information on the data we make available is made available to the beneficiaries we trust.
Outstanding. Josh, did you have any thoughts? Are you still online?
I am still online. The only quick note is just to say, and I think this is implicit, but just in terms of how I think about this, approving an app is actually a process with two steps or two gates in it. First, the app needs to be introduced in a technical way to the underlying clinical system or payer system. And then second, a patient needs to connect and approve, which is to say, okay, yes, these are the types of data I'm willing to share with the app. And until both of those steps happen, no data flows. So both of those are important steps. I tend to give consumers a lot of benefit of the doubt here to make the right kinds of decisions and inform themselves. A lot of discussion up to this point has been about the first step. I just want to emphasize that if that first step doesn't happen, a consumer really can't even make the choice.
Agreed. And what do you think if you change the stakeholder from the consumer to the provider? Where, as a payer, we have some examples from, some of the opioid clinical decision support tools that were released that unfortunately weren't necessarily in the best interest of the consumer. Do you see maybe 5 years from now, I don't, how far out, but at some point we're going to be sharing data with approved apps and evaluating those approved apps from a clinical perspective as well? Would you leave it to the individual physicians to determine which apps, or do you see a need for us to have a collaborative effort around that as well?
Yeah, I mean, at that stage, the question becomes, what is the authority of an application to work with those data? And there's a few kinds of regulatory constructs we have for those kinds of things today. One is business associate agreements, and that's sort of the kind of data flow that providers are most familiar with and comfortable with today. when you think about moving data outside of a covered entity and not under an individual's choice, the question becomes, okay, well, what's the framework for approving that access? All of the rules that follow from the 21st Century Cures Act are predicated on an entity being authorized to work with the data. So once you're authorized, how do you make the data flow? So I think we have to understand what are the different pathways to that authorization first.
Excellent. And I think, in the long run, when we have a trust framework that allows dynamic app registration, being able to at least reduce the burden by trusting third-party validators may help.
Well, thank you, gentlemen. I appreciate your time. It's been a very nice discussion, very lively, and thank you for extending healthcare interoperability.
Thanks, Ed. Thanks very much.